you for joining us. Today, we have a magnificent talk by Dr. Mary Wilson on SARS-CoV-2 transmission routes and roadblocks. Let me tell you a little bit about Dr. Mary Wilson, whom I met almost 40 years ago when I was a student at Harvard School of Public Health. She was the chief of infectious diseases at Mount Auburn Hospital and a professor at the School of Public Health. She's currently still associated to Harvard and also a clinical professor at Epi and Biostat at UCSF. She has written extensively on travel medicine, on antibiotics. She has books on those topics, an expert in neglected tropical diseases and zoonosis. So it's a real privilege to have Dr. Mary Wilson with us talking about SARS-CoV-2 transmission. Dr. Wilson, you have the floor.
Thank you very much, Dr. Sepulveda. It is a pleasure to be here, and I look forward to discussing this topic with all of you today. Okay, perfect.
There you are.
Okay, there, okay. Thank you very much. Thank you for that introduction, Jaime. I'm looking forward to discussing this message, this topic today, which is one of, I think, great interest to all of us. In order to deal with and control the current pandemic, we really have to understand how the virus is transmitted, how it is being transmitted, and what we can do to interrupt the spread. There are 5 key messages I would like to focus on today. First, spread of the virus through the air is a predominant route. Much is known about respiratory emissions from infected individuals, and we can think about how these emissions are produced, but also how they are deposited in another individual. The indoor environment is important in determining the survival and fate of these respiratory emissions. With SARS-CoV-2, super spreader events seem to be extremely important in the epidemiology and are important in the transmission in many settings. And finally, masks are an essential part of layered interventions, and we'll talk a bit more about each of these. I also will say that roadblocks to the use of effective interventions include behavioral, socio-cultural, economic, political. I'm not going to talk about that specifically, but that's something we may want to come back to with the discussion. Well, transmission routes. Some of the cartoons are helpful in giving visualization of the variety of ways that the virus can spread. And this is a slide that actually was from a study of SARS-1, that caused the outbreaks in 2003, 2004. But there are many similarities with our current SARS-CoV-2, and what we see is that close contact is important. One can see in this cartoon that there are there are many different sizes of particles that are being produced. Fomites, viruses that contaminate surfaces, are important, but you also see that there are particles floating in the air that can in fact, contact someone who is at some distance and away from the immediate person who is infected. The other thing that I will mention is that that has not been discussed in some instances is that materials, viruses on surfaces can be re-aerosolized. And that is one of the reasons why cleaning is so important. Well, this is just a different cartoon showing routes of transmission, certainly directly person to person, but it's not enough to touch another person or an item with the virus. One then has to take it to one of the mucosal surfaces, such as the mouth, the nose, the eyes, where the virus can gain entry. But again, we see that the main risk is in this plume of either cough or breathing that goes into the face of another person. I don't know if you can see it on your screen. On mine, the far side is blocked, but it also shows that in healthcare settings, there's aerosol generating procedures. Well, so the transmission, some people prefer to use the word spray to describe the large droplets that hit the eyes, nose, and mouth when in close contact within several feet, often within 5 or 6 feet of someone who's infected. But with close contact, you also have an aerosol that can be inhaled, and the smallest droplets can actually be deposited in the lung. So with close contact, you have both the large and the small. With the longer distance, in fact, it is the smaller droplets that can float in the air and can persist. We've mentioned touching mouth, nose, eyes after contact and re-aerosolization. We don't know, there's not a standard breakdown of how much transmission occurs by fomites, by close contact, by longer distance, and it really depends on the activities, the circumstances, and we'll talk about some of the factors that can influence these various routes of transmission. I think it's helpful. This is a paradigm that Don Melton, who actually spoke at one of the grand rounds, or one of the rounds recently, who's really spent much of his lifetime looking at airborne transmission of infections. But this was a piece that he and another colleague wrote in the New England Journal after SARS-1. And I think it's a useful way of thinking about how pathogens are transmitted. There are some that are transmitted only by the airborne route, like tuberculosis. There are others that preferentially are transmitted by the airborne route, infections like smallpox and anthrax. And then there are those that are opportunistically transmitted by the airborne route. And I would put SARS, the original SARS, SARS-CoV-2, and MERS in that category. They can spread very dramatically in some instances by the airborne route, but much of the time they may be spreading by close contact. And this is a short piece that was just published, and again, I think has a more nuanced picture of the transmission mechanisms. And what you see in the index case, the top part of the slide, is that you have particles of many different sizes that are created when someone, actually even when a person talks, but particularly when they cough or sneeze. And the large ones don't travel very far, but if you are within several feet of a person, the spray can hit, and if it reaches eyes, mouth, or nose, can in fact transmit virus. But there are there's a whole range of sizes of particles that are created routinely or normally when people breathe, talk, or also when they're cough. But the size is really important because the size determines the, actually go back for a minute, the size determines the survival, the deposition of the particles. You might ask, how on earth do scientists learn how the various sizes of particles? And this is from a laboratory at the University of Maryland where they have an aerobiology laboratory and have for years been studying the behavior of particles, the sizes, which ones contain viruses. And this is from the group at MIT that has provided some very vivid visual reminders of what happens with breathing. And many of these are now online, and the New York Times even had some of them. But if you want to get a real-time image of what happens with cough, sneeze, and other activities, you can do so. But this shows that a sneeze is, and in this particular article, it's described as a turbulent gas cloud or a plume that goes out from a person. But these have been measured in terms of distance, velocity, and the persistence in the air. For years, there's been a lot of work that has been done about about the size of airborne particles and their behavior, but much of this has been done by engineers and by people who are studying particle behavior. And there's really been, I think, a certain disconnect between the clinical setting and some of the basic research that has been done. But one can talk in terms of respiratory emissions, and when one breathes, talks, coughs, one produces emissions that range in size well under 1 micron to more than 100 microns. Where these come from in the respiratory tract determines the size, but vocalization profoundly affects the distribution of sizes as well. For example, it makes a big difference whether one is breathing quietly, coughing, singing, shouting, or carrying on other activities. And the size of the particles determine how long it survives, where it settles, either dropping to the ground or potentially reaching the lowest part of the respiratory tract, how far it's transported. And it's useful to look at at a diagram of the respiratory tract, and in the upper part, one sees the largest particles that are produced, and in the tracheobronchial tree, there are somewhat smaller, but the smallest ones typically come from the lungs, from the lowest part of the respiratory tract. The emissions are highly heterogeneous from one person to another. When these have been looked at, there can be more than 100-fold or greater difference, even with normal breathing. Consistently, in every study I have seen that has looked at emissions, respiratory emissions, there's a certain percentage of people who are what are called high emitters or super emitters, people who produce higher numbers of particles than others. And this happens in normal, healthy individuals who are being looked at, and it also occurs in respiratory infections. And this is a study from several years ago that looks at influenza and basically looked at patients with acute influenza who were admitted to the hospital and collected material at different distances from the patient. And what they found was that literally, and each of the lines on this, and at the bottom you'll see the age and some basic information about each of the individual participants. But what you see is the number of the aerosol concentrations of influenza virus that was emitted over a 20-minute period of time. And what you see on the far right is that you have a small percentage of the people who emitted vastly more than all of the others. And this is a pattern that is repeated over and over again. This is a study that was published before the COVID pandemic, but in fact is highly relevant. It was published in 2019, and the researchers basically looked at aerosol emission during normal speech, but also with voice loudness. They also, interestingly, looked at people speaking different languages and asked, are there certain sounds, are there certain kinds of vocalizations that are associated with differences in the aerosol emissions? On the left-hand side, you see individuals who are asked to speak quietly, with an intermediate level of loudness, and then loud. And what you see in the blue line, for example, those who were speaking loudly emitted many, many more particles than those who were speaking in a soft voice, which is the lowest curve in sort of a yellow gold color at the bottom. And the size distribution also varied. You have mostly low, you have small diameter. Many of the particles were 1 micron or less. The other figure shows the number of particles that were actually emitted by individuals. They were all asked, there were 30 of them in this part, they were all asked to read the same passage and in a normal speaking voice, and then they looked at the number of particles that were emitted. And I don't know if you can see all the way to the far right, but again, you find a small number of people who emitted large numbers of particles. And this looks at again, this is from the same study. They asked, what if people breathe in different ways? And so they looked at people breathing through the nose, through the mouth, various patterns of deep and fast, or fast and deep, and then with various levels of loudness. And again, what they found was that there's marked variation, again, with loudness producing, you see this on the far left, the number of particles are much larger with the loud speech, and the figure on the right shows the size, and you see from one individual to another there is substantial variation. Note on here the red plus signs, and those showed the outliers, and particularly look at the number of particles on speech. And in each instance, you found a few individuals who were way outside of the normal distribution. Well, the other, so not only does, so where the particles land in the respiratory tract may affect disease severity, and some of the work that Monica Gandhi has done recently also looked at the inoculum and whether the size of the inoculum can influence the severity of disease. There's also been some nice work in animals that showed that with showing differences in the inoculum and the severity of outcome. But location of deposition may also influence the clinical outcome. The SARS-CoV-2 virus uses the ACE2 receptor to attach to cells, and the expression of ACE2 varies greatly in different tissues within the body. And in this particular study, they looked at ACE2 expression in various parts of the respiratory tract and found that, in fact, there is a gradient of expression from the upper to the lower respiratory tract. And the nasal mucosa, for example, is very richly, has a very rich expression of the ACE2. So the virus seems to be able to infect very easily in the upper respiratory tract, and basically can infect the rest of it as well. But they, in this particular study, showed a gradient in the respiratory tract. Interestingly, people who are infected in the nose or the upper respiratory tract initially can also, their lungs can become infected because they inhale very small particles that initially infect the lungs, or they can also develop lung infection because of microaspiration of material from the upper respiratory tract. And one may see a combination of both factors involved in the spread. Well, we know that virus can be found, well, that people produce particles of varying sizes. What is some of the evidence that infection can actually be airborne? And there are nice studies that look at the survival of the of the virus in the air, and one that was published in the New England Journal of Medicine in March actually looked at not just PCR, but actually looked at the presence of viable virus and found that in a laboratory setting, aerosolizing virus could produce virus that would survive at least 3 hours. The half-life of survival was 1.1 hours in the air. And in that particular study, they also looked at survival on various kinds of surfaces to get some sense how long it is likely to persist. But there have also now been a number of studies that have looked at the hospital environment to determine where virus is found. And I'm going to just show one of the studies. This came from Singapore, and even though they did not have very many patients, it was a very carefully done detailed study, and they looked at the airborne concentrations of virus in adjacent to some of the patients, and found in fact that they could easily find virus in the air adjacent to patients. They also looked at contamination of surfaces, including ones that were more than 6 feet from where the patients were in bed, or where they were located. But the other thing they looked at is by day since onset of illness. And what was striking, and again, I don't know if you can see all of the figure on the far right, but the virus dropped off very rapidly. The number of surfaces, the percentage of surfaces that were contaminated dropped off rapidly after 7 days, and they were most likely to pick up virus early in the course of infection. Well, there are also animal studies that support airborne transmission, and at least 2 laboratories have shown airborne transmission in ferrets. Ferrets are susceptible to SARS-CoV-2. They shed virus in nasal washes, saliva, actually also in urine and feces. And at least 2 different laboratories showed that physically distanced ferrets could transmit the virus. But there are 3 epidemiologic events that also provide, that are hard to explain without implicating airborne spread of the virus. And there are others as well, and other super spreader events, but I'm going to just briefly mention 3 of these. This was a call center in South Korea, and what you see here on the slide is a map of the 11th floor, and every blue area on the top part, and in the bottom as well, but every blue area is a person who became infected. And what they found was that on this particular floor of this high-rise building, where they had a call center, of the employees, 43.5% became infected. And if you just look at the distribution, it's not as if there's concentric areas where they were in contact, where it was obvious in the way that it was being spread. And the only way that it made sense to explain the transmission here was likely through airborne spread. They did look at the secondary attack rate in family members, and that was about 16 or 17%. The second one is an outbreak that I think everyone's probably heard about, and this was the choir practice in Washington State, where 87% of people who attended a single choir practice became infected, and actually 3 people were hospitalized, and there was at least 1 death related to this outbreak. So even though people apparently took some precautions, they spent 2.5 hours vocalizing, which is one way to really produce a lot of respiratory emissions. And the third one that I will mention briefly is one that was just published this week. And this was on a bus in China. And there were 68 people on this particular bus. The figure here shows the actual map of the bus with one rectangle for each person, and in red, in the sort of the middle of the bus, you will see there was one person who was infected. The person was not symptomatic. At the time, there were two 50-minute bus rides that occurred to and from an event. But this person was not symptomatic during the time of the bus ride, but that evening developed symptoms that were then diagnosed as SARS-CoV-2. But what you can see is the number of people who were infected. Some had mild, some had moderate. The pink ones are those with moderate disease. But basically, this was a bus that had recirculated air. And so, although some of the people seated by the vents and perhaps there were a couple of windows that were open, but basically more than a third of people on the bus during two 50-minute bus rides became infected. And again, it would be hard to explain this without implicating airborne spread. Well, several groups have tried to look also at the role of super spreading events, and several of them have suggested that perhaps as many as 80 or as much as 80% of transmission is related to 10 or 20% of those who are infected, that many people who are infected, many COVID patients don't infect anyone, but there are some who infect a very large number, and this is really important in the epidemiology. And I think of super spreader events, and I think it makes more sense to talk about the events rather than the particular person. But one has to have sort of the perfect confluence of circumstances in order to have one of the events. And it depends on the person, the stage of infection, the environmental conditions, the number of people who are potentially in the area, and the activity. And for example, we know based on years of other work that's been done, there are some people who naturally have high respiratory emissions. So one could postulate that many of these super spreader events involve a person who happens to be, and people don't know unless they've been in a lab, they don't know whether they're normally high respiratory emitters. Early in the infection is most likely the people in general shed the highest amounts of virus very early in infection, often before they become symptomatic, or some never become symptomatic. And so they're still continuing normal activities, interacting with other people, unaware that they can potentially spread infection. One needs the right environmental conditions. And this is typically indoors, a closed environment, poor ventilation, or recirculated air. You need lots of people, so you can infect, in some instances, dozens or more than 100 if they are within that breathing space. And there have been a number of examples: church, cruise ships, and elsewhere, the bus that I just mentioned. And then people spread more effectively if they're singing, shouting, cheering, and people who are exercising or undergoing physical activity also emit more because they're breathing more deeply and more frequently. This is a model that was just part of an article that was just published in JAMA that modeled what a room would look like that was at various levels of ventilation, and in fact, over time, how much virus could potentially accumulate. And the upper line shows this. So they were assuming a person who is a high emitter and is infected with SARS-CoV-2 and was coughing occasionally, and then modeled based on the known particles that can be emitted by individuals what would happen in a room. And the top line shows one air exchange per hour, which is very low. And as you can see, you can really accumulate a substantial amount of airborne virus particles in a poorly ventilated room. The the dashed line shows 3 air exchanges per hour, and the lower 2 show 10 and 20. So clearly, the amount of ventilation makes a big difference in whether or not virus particles can accumulate in a room. Hospitals typically have about 8 exchanges per hour, ideally anyway. Typical office buildings maybe have 3, although many are lower than that. Schools are supposed to have 4, but that may not be followed. Airplanes, actually, the newer ones typically have about 20, but here you have a densely packed body that is body of the airplane that is filled with people. Well, so what can we do? Masks, as all of you know, are not new, and it's interesting to look back. I mean, the last time where masks were in the news regularly was more than 100 years ago with the 1918-1919 influenza pandemic. And I love seeing some of the clippings, open-faced sneezes to be arrested, church windows must stay open, and all of the newspaper clippings that that were appearing. But there also were demonstrations against the use of face masks then, and others who were strongly advocating for them. But today, unfortunately, the use of masks is more controversial than it should be. And in fact, there is evidence. It's impossible to do a double-blind controlled trial of masks in the real world setting, but there are been many kinds of evidence that have been generated about the benefits of using masks. This is one study that basically looked at states that mandated community use of face masks when in public for everyone, and states that did not. This was published in Health Affairs this summer, and showed, and again, I don't know if you can see the part that's behind the insert, but basically showed a decrease in the growth rate of new infections in those that had face mask mandates. And there have been many studies in the laboratory and elsewhere that show the benefits. There's no place where you can find any study that says face masks will prevent all transmission of infection. They don't, but in fact, they can be highly effective, and particularly when they are used by both what I would call the donor and the recipient, by both the person, by all individuals. So there's been discussion of, that to me makes a lot of sense, what is called layered interventions, and it starts with face masks or other coverings, and this should include ideally eye coverings, certainly anyone in a healthcare setting, but mask use should be in areas with transmission, should be universal, with exceptions in unusual circumstances where someone cannot tolerate it for very precise or specific reasons. But the fundamental intervention that all should be using as part of the layered interventions is masks. But then it also includes hand hygiene, physical distancing, cleaning surfaces. And this, I think, is sometimes ignored, but it turns out there can be re-aerosolization. And in the studies in hospitals where they've sampled rooms and floors and toilets and other places before and after cleaning, they find that cleaning removes all or almost all of the virus. So, and these can be, particularly in rooms where people are doffing their personal protective equipment, there can be a virus that contaminates those areas. One should use the outdoors when possible. One needs to improve ventilation, quiet, it turns out, is better. And in fact, if you were on an airplane and wanted the lowest risk, it would be nobody talking, nobody eating, because you have to take a mask off to eat, and talking, even talking, quiet talking, generates more particles than not talking. And then one would limit number of contacts and the size of gatherings. Environmental conditions affect the survival of the virus. The virus survives better in cold temperatures, and it survives better in low humidity. And if you think about the meat packing places, processing and places, often these were really cold environments, and with people right up next to each other, working in very close contact, and it was sort of the ideal setting for the transmission of the virus. Ventilation is important, and sometimes people confuse what ventilation means. Sometimes people think it may mean just putting on a fan and moving the air around, and it's not. Ventilation means bringing in clean air. And the simplest way to do that is to open windows. Unfortunately, in many places, it may be too hot, too cold, too smoky, or these days, or there may even be places where people live in apartments where the windows will not open, or it may be dangerous or risky to open windows. So it's a nice idea to think about opening the window and allowing the fresh air to come in, but in reality, it may not be as easy. And then air exchanges per hour really can be need to be looked at. In the drive to conserve energy in past years and even today, buildings were often made tighter and more energy efficient. But it turns out that the older, leakier buildings in some ways may have provided or allowed more outside air to enter. And it may be that, one of the problems with providing better ventilation or increasing air exchanges is that it costs. There's an economic aspect of these kinds of interventions. But I think we're going to be hearing more about these. So what are some of the interventions to reduce airborne spread? Well, spend as much time as possible outdoors, because the outdoors is really pretty safe. You have dilution, you have sunlight. That's not to say you can't have transmission outside if you have people crowded together outside, and if someone is within someone else's respiratory plume, it can still be transmitted. But in fact, the riskiest places are indoors. Increase ventilation, as I mentioned. If you can't stay outside, bring the outside air in. There's a lot more looking now at filtering air, and some places do this anyway, but I think this will be looked at more systematically. There are also air cleaners and that can be used. Some of these are portable air cleaners that are sized to the particular area and may be particularly useful in areas where there are potentially a lot of people in close contact. A colleague in Germany has talked recently about how these are used very frequently in some offices and waiting rooms and other kinds of settings. So I think many more people are going to be looking at the potential for possible air cleaners. UV light, sunlight by itself is good because the virus doesn't survive well in sunlight. But there's been a lot of work, particularly around tuberculosis, over many years, looking at the use of UV light. And it's been used in a couple of different ways. One is putting it in the ceiling because you have air rising, and installing UV lights in the ceiling that do not come into contact, do not hit the individuals who are in the room, but it can help disinfect the air that is in the room. And in some places, they've also looked at installing UV light in the ducts, the air for the air that is going into the rooms. They caution, though, that the air has to be at such a flow that it is there long enough that it can actually be disinfected by the UV light. But this has been, this is not specific for SARS-CoV-2, and certainly works has been shown to be effective for tuberculosis. So this would be a broader spectrum intervention, but this is something I think we'll be hearing more about. You can limit the number of people in the room, and what is absolutely the worst, which has been shown by the bus outbreak and other situations, is you really want to avoid just moving the same air around and around without bringing in fresh air. This is just a diagram that shows recent review that looks at the various ways of improving the quality of indoor air and reducing the potential for spread of SARS-CoV-2 and other infections. Actually, as an aside, it's been interesting to see the decrease in influenza transmission at a time of COVID interventions and physical distancing, and the many of the same mechanisms allow influenza and other respiratory viruses to spread. And this is the last figure from the literature, and this is an article that was just published where a group really tried to put together, integrate many different kinds of interventions and think about level of risk based on indoor, outdoor, level of ventilation, the degree of vocalization, whether or not face masks were being used, and how crowded the environment was, and what you see down here in red, you have no face coverings, speaking, shouting, singing, and in poorly ventilated areas, and those are all red. Those are risky situations. But you can also, this tries to lay out some of the relative risks in different kinds of circumstances. Individuals have control over many of their activities, and they certainly have control over the use of masks and physical distancing. So let me just return to the key messages that I have tried to provide today. Spread through the air is very important. It can spread through fomites and other ways, but airborne spread is really important. There's a lot that is known, but different terminology and language has sometimes caused confusion in making recommendations. Indoor environments are really important. Super spreader events drive spread in many areas, and masks are an essential foundation as part of the layered interventions to interrupt spread. And there are still many roadblocks. Even though we know what is effective, there have been many roadblocks to using those interventions. And with that, I will stop and look forward to any questions or comments.
Thank you. Thank you so much, Dr. Wilson. This was a fascinating talk. I can see there are already a number of questions posed by the audience in the Q&A. Colin Boyle will be helping curate the questions for you. Welcome, Colin.
Right.
And I do have some questions of my own, but I want to give the opportunity to have these questions that have already been posed by the audience to you. Colin?
Great. Thanks, Dr. Wilson. It's good to see you again, and thank you for that wonderful talk. There are a number of different questions. I'll try to categorize them. There were a couple that were specifically about some of the case studies of the super spreader events that you described, the bus, the call center, the choir. And I guess one question that has emerged is that since those are, we have millions of infections, and given the number of case studies that the Washington Choir keeps coming back as an example, is that as pronounced and prevalent a route of transmission, these events, these large-scale groups, or are there other explanations that might explain? For instance, do the call center people all kind of go together to some sort of other indoor event that might suggest it's more than aerosolized or transmission under that route?
Well, I think those are important questions to ask. In the bus example, they actually did look carefully. They had a control bus that also went to the same event and had the same kind of exposures at the event. I mean, they did look carefully at that. With the on-call center, they did mention that the individuals shared, some of them would have used the same toilet, but it still would be very hard to explain the distribution. I mean, and other mechanisms may have contributed, but it would be hard to explain the totality of the distribution by fomites or some other kind of touching mechanism.
Okay, great. And then a question about aerosolized transmission, and specifically a comment you made about the virus surviving longer in sort of low humidity settings. Is there a reason to think that higher humidity settings would allow for greater aerosolized transmission because of water content in the air or factors?
The studies that have been done that have looked at by level of humidity have not, the ones I've seen have not shown longer survival in higher humidity. And so I mean, the behavior of particles really varies depending on the humidity and what happens with particles and droplets that are emitted, for example. There's often a certain amount of evaporation that occurs from those, and one ends up with smaller particles than one starts with. And so I don't know whether in the higher humidity, the droplets are more likely to drop out more rapidly and fewer of them float, but there's more than one lab study that really have looked at that, and it causes concern because we are going to be approaching winter months when it's colder and drier, particularly in many parts of the country. It's always hard to sort out how much of increased transmission of influenza, for example, is due to environmental conditions and how much of it is due to the way we live. I mean, we spend more time inside during the colder months as well. But there have been looks specifically at the virus, and it seems like cold and dry.
Okay, great. And then there were a few questions about ways to protect ourselves. So, one question you talked about, some of the issues around aircraft. Would you get on a plane now?
I have personally, because I'm in a high risk group, have decided I'm not ready to fly yet. And I used to fly all the time, or very regularly. And to me, I mean, even though the air's clean, I mean, they filter it, they're high air circulation. And even though some airlines are asking everyone to wear masks, I hear that not everyone does. And it is really a crowded environment. And I don't feel comfortable yet, particularly, well, when there's a lot of transmission. And in the US, there's still a lot of transmission. So at this point, I don't, but if I were in a, in a higher risk group, I might, but I'm not ready to fly yet.
You're playing it safe. Okay.
Um,
And then a few other questions about things that we can do in addition to the layered interventions and the better ventilation. The eye has been discussed as a sort of route of introduction of the virus into the body. And yet a lot of your talk was about the respiratory route being more prominent. Just wondering if you have any comments on masks versus face shields or how important that distinction is.
Well, I think that, a couple of comments. I mean, eye protection is really important if you are in a healthcare setting or if you're in a household where someone is infected. I mean, because infection can enter through the conjunctiva, or people can rub their eyes also. So eyes are important, and one of the things a face shield does is keeps you from touching your face. The face shields do not eliminate the potential for the aerosol to go around it. I mean, it can still enter from the side. Well, it depends on the construction, and some of the shields now are much better, are constructed in a better way to try to eliminate some of the going around the shield. But in some settings, you want both a mask and a shield, and but eye protection is important.
Okay, great.
Harry, if I may, you did mention that in ferrets, the virus has been recovered both from urine and from feces. We know that in the intestinal epithelium, we have ACE2 receptors, and in humans, the virus has been recovered from feces as well. Why is it that we do not have so much of a oral fecal transmission as we have seen with many other viruses?
Well, I guess the first thing I would say, we don't know that it never occurs. And I think some people are concerned that there could be fecal transmission. And with SARS-1, in the Amoy Garden outbreak, in fact, there was aerosolization of fecal material that led to cases. So under the right circumstances, potentially with this virus as well. I mean, it has been recovered, but it doesn't seem to be present in high amounts in the feces, but it can be recovered, and it potentially could be. But I think it may have to do with the amount and sanitation. I mean, it's so, I mean, people emit from, I mean, we are producers of respiratory emissions regularly, and it's so much easier to send out your plume from the respiratory tract, and the other end is more contained, and so, and it has to do with the amount. I mean, there's huge amounts of virus in the respiratory tract, and relative. I mean, they have been able to recover it from the feces, but it's been in relatively small amounts as well. They have not. I don't think it's been recovered from urine in humans. I mean, in ferrets, you can get it. Can find it in the urine, but I don't think we found it there in humans.
And just one last question from me. I'm curious, what's your opinion on reinfection? We have seen some well-documented cases of reinfection. Do you anticipate we will see many more?
I don't know. I mean, I was really sad to see those, because we have all been hopeful that infection would produce at least good short-term, I mean, meaning maybe a year or two protection. And, you know, are these the 1 or 2 cases out of 1 million? Or are we going to see those? see more of them. I mean, what was really upsetting was to see in one case, the second episode seemed to be more severe than the initial episode of clinical episode, which was very mild. So I don't think we know. And so many people we know have been infected and have been asymptomatic despite documentation they were actually infected. And they have not developed a very robust or very long-lasting antibodies. So I don't think we can assume that reinfection can't occur. And even more reason why we need a vaccine that I think we will be wanting to give to everybody, including those who may have been infected, particularly those with mild infections. I mean, had mentioned to you before, I mean, SARS-CoV-2 makes me humble because we keep learning. We think we know something, and we've learned so much so fast. When you think what we've learned in the last 6 or 8 months, it's really been pretty astounding, but we still are surprised. It seems like every other day something, whoops, we didn't expect that. And I think that will continue. There's more to learn.
Back to you, Colin.
That's it, Jaime. We've covered all the questions.
So this has been fantastic, Mary. Really, really much appreciated. I see many comments applauding the clarity of your slides, of your concepts, and very appreciative of for this excellent presentation. For our audience, a reminder that now we have gone to bi-weekly series, and the next speaker will be Dr. Peter Hotez. Now, this will be a joint session with the Department of Medicine and will not take place on a Tuesday, but on Thursday, September 17th. So just wanted to give you a heads up that it will be a joint session on Thursday, September 17th with Dr. Peter Hotez, and the topic will be on vaccines. Please join me in thanking Dr. Mary Wilson for her extraordinary talk and great disposition to help explain very difficult concepts to all of us. Dr. Wilson, thank you so much.
Thank you.
Stay safe, everyone, and thank you for joining us. Goodbye.